All right. Hi, everyone. On behalf of Screen and J and Rutgers Cancer Institute, hello and welcome to Community Cares and Project Echo. Thank you so much for joining us today. We hope that the information shared today will help you serve your community better. And we have a few announcements before we begin the presentation. So this is just a quick disclaimer that the information contained in this presentation is not substitute for a medical consultation, and a physician should always be consulted for any health problems or medical conditions. So today's agenda, we're going to do a Project Echo series overview, introductions. The actual presentation and case study are kind of intertwined today, so that'll be really interesting. And then we'll do questions and answers at the end. If you have questions throughout the presentation, please put them in the chat and we'll go over them at the end. So a little bit about Project Echo. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. So for more information on Project Echo, you can go to echo.unm.edu. And today, our speaker is Dr. Marshall McKenna. Dr. Marshall McKenna is a hematologist oncologist at Cooperman Barnabas Medical Center who specializes in malignant hematology, particularly leukemia, lymphoma, and I'm going to have some trouble saying some of these words, myelodysplastic syndrome, myeloproliferative neoplasms, and myeloma. Prior to joining CBMC, he completed his residency in the internal medicine at Rutgers, New Jersey Medical School, where he was named chief resident. Dr. McKenna completed a fellowship in hematology oncology at Rutgers Robert Wood Johnson Medical School and at the Rutgers Cancer Institute, where he was selected as chief fellow. Dr. McKenna has been actively involved in clinical research throughout his career. He was the recipient of the Melvin H. Monalowski Research Foundation Award for Excellence in Hematology Research during his fellowship. Additionally, he has authored and co-authored multiple original articles and abstracts on different hematologic malignancies and presented research at national and international conferences. In collaboration with the Rutgers Cancer Institute, he has offered his patients innovative therapies like immunotherapy, bispecific antibodies, CAR T cell therapy, and hemopoietic stem cell transplantation, while also striving to advance current treatment modalities through patient-centered clinical trials. And we are so lucky to have him here today. So thank you, Dr. McKenna, for being here. And I think I can hand it to you now.
All right, great. Thanks so much, Sarah. I appreciate the introduction, and it's a privilege to be here today. And thanks everybody for joining. Like Sarah had said, I work at Cooperman Barnabas Medical Center, which is the northern region hub for the RWJ Barnabas healthcare system, which is the largest healthcare system in New Jersey. And I'm also on the faculty at the Rutgers Cancer Institute, where I work in close collaboration with the heme malignancy people down there as well. So today we're going to discuss the basics of malignant hematology. So that is a incredibly broad topic that we could probably spend weeks, if not months, discussing. Especially since hematologic malignancies covers, hundreds of different lymphomas, dozens and dozens of different leukemias, and multiple nuances to myeloma, as well as other heme malignancies. But since we have a broad audience from a lot of different backgrounds, I thought it'd be interesting to kind of focus more on the aspects that we're all familiar with, right? And that's looking at a CBC or a complete blood count, and really looking into kind of what those results kind of mean in the whole context of hematologic malignancies. And I think something that we're all familiar with, either in describing it to our patients or just looking at our own my chart and trying to figure out what all those red numbers mean. So with that, you can go to the next slide. So here we have a pretest, and my hope is that in looking at these questions now and then looking at them later, we'll be able to kind of sort out the answers to these.
Evelyn, are we able to pop up I don't know if I can do it on my end. The pretest? Yeah. So we'll give everybody a minute or two to complete the pretest and then we'll move on.
Just gonna give it another second or two. Okay, we'll go ahead and move on.
All right, great. Basically, objective today and kind of a rough outline is to review hematopoiesis. So another name for blood cell maturation. So I have a few pictures, kind of throughout the presentation that kind of describes that process and how it relates to CBCs. And with that, hoping to better interpret, CBCs for ourselves and our patients moving forward. We'll review some abnormal CBCs through cases, and then kind of some of their diagnoses, and then have a Q&A session at the end. Okay, so one of the probably most common consults that I get both in the office and in the hospital is for abnormal blood counts, right? And one of those abnormal blood counts that I get consults for is something called neutropenia, so low neutrophils. So first things first, before we kind of get into what that means, let's just briefly go over kind of the whole maturation process of blood. Okay. So here I have two pictures, and we don't really need to focus on the one on the right-hand side. Really, the only reason that I have it there is just to kind of give some insight as to how complex this whole process can be. Really, that's more for, the myself and pathology to kind of focus on some of the nuances of disease. But the picture on the left side, I think, is important because it gives some context as to what all the CBC numbers actually mean and where they're coming from. Okay. So we can go to the next slide. So here on the left-hand side, we have just a normal CBC, okay? So something that we're all familiar with, okay? So I've kind of highlighted some of the more important information that you can get out of this. So you have a white blood cells, okay? And white blood cells generally are responsible for fighting off infections and responsible for our immune system. Then we have hemoglobin, or another marker for red blood cells. It's actually, we follow hemoglobin a lot more than we do the red blood cell count when we're talking about that. And then in green, we have platelets, okay? But then I'll just kind of point out, and I try to point it out with some circles and some color coding as well, where you can get a little bit more nuanced into what different white blood cells mean, okay? So there's lots of different types of white blood cells. And here we have neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And those are circled in blue. Okay. So one thing I want to kind of mention, right, is that all blood starts off as a stem cell, as it does for lots of different types of processes within the body. So we have a stem cell that can then differentiate or go into two different types of early progenitor cells. One side is the myeloid side, which is on the left-hand side, and one side is the lymphoid side, which is on the right-hand side. Okay. So in myeloid cells, those can differentiate and become our red blood cells, our platelets, and some of our white blood cells. Whereas the lymphoid side can go into the different types of lymphocytes. Okay. We don't really need to get into too much detail about how these different white blood cells are involved in the immune process. But a few things I want to point out is that on the lymphoid side, that's where we get some regulation of our immune system and also get antibody production. Okay. And what antibodies are is, for instance, if you get exposed to the flu, right? Or if you get a vaccine, you produce antibodies. And those antibodies are helpful down the line if you ever get exposed to a flu or COVID or whatever it is to help fight off infections in the future. Okay. So that's more on the lymphoid side. On the myeloid side, we briefly touched upon, red blood cells and platelets, but there's other white blood cells there, okay? So basophils and eosinophils are involved in certain parasites and allergic reactions. Monocytes are responsible for, kind of gobbling up bad cells, or gobbling up bacteria and things like that. And the neutrophils are a really important cell involved in trying to in bringing the immune system, kind of first line of the immune system to kind of fight off a lot of different things. So inflammation, infections, and things like that. So neutrophils are really important for that first line of defense. Okay, we can go to the next slide. So let's kind of talk about a case, okay? And kind of bring this into context. So this is a 67-year-old man. He has a history of hypertension, high blood pressure. He's on a combination blood pressure medication. He presented after his PCP found to have an abnormal white blood cell count. He told me he felt totally fine, no fevers, no symptoms, nothing at all. He has not had repeated hospitalizations, no repeated illnesses, and he feels really well. He feels totally fine. And what he then tells me is that his entire life, he's been told that he has a low white blood cell count. So we can go to the next slide. All right, so here's that picture that I have again, okay? And here we're focusing on low white blood cells, low neutrophils, right? And just to remind you, that's kind of the initial, the responsibility of the neutrophil is the initial immune response, in our bodies, okay? And this was his CBC, right? So really the two things I want to point out here is that his white blood cell was low, okay? And his neutrophil count was low, 0.7, okay? Um, you know, just for some context, it also shows that his percentage of lymphocytes was high. But what I focus on a lot more in my practice is actually the absolute number, because that's more important. So his absolute number of lymphocytes was normal. So really the only thing that's abnormal here is his neutrophil count, okay? So one thing to point out is that there's gradations of neutrophils and how severe a low neutrophil count is, okay? So mild is considered 1.0 to 1.5. Moderate is considered 0.5 to 1. And severe is considered less than 0.1. So I would classify this as moderate neutropenia. But that doesn't exactly tell the whole story. You can go to the next slide. So some things I want to point out is what he told me, right? So he's been stable on a blood pressure med for a long time. He feels well. He hasn't had any issues with repeated infections, despite having a neutrophil count that was in the moderate range. And he's been told on CBCs his entire life that they're low, without really any story of any issues in the past. We can go to the next slide. So, one clear concept that I want to reiterate here is that it's important to understand the trend of somebody's blood counts over time, right? So both before and after, some event, and also what the patient is telling me. So we kind of already talked about that, this is a patient that feels really well. But I want to show you that his CBC over the past, 2 to 3 years has really, really been stable, right? So he has been essentially neutropenic or has a low white blood cell count going back at least 3 years, right? It's ranged between mild and moderate. But something that I think is reassuring that maybe this isn't all that clinically significant. Okay. All right, we can go to the next slide. But what I would say is that it's important for me, in seeing a patient like this is yes, the story can tell one thing, and the blood count can tell another thing, but it's important for me to make sure that there's nothing else going on and that there's no other reason for this. So, outside of certain malignancies, there's lots of different causes of a low white blood cell count and lots of different causes for a low neutrophil count. And these are some of them here. So sometimes you can see abnormalities in, B12, low B12 counts, low folate, low copper levels. This can be associated with liver disease. So, patients that, have cirrhosis or other liver issues can sometimes have a low white blood cell count. Patients that have HIV or hepatitis, like hepatitis C or hepatitis B, often, we'll see this in the hospital that somebody's very, very sick in the ICU and they have an infection in their blood and it drops their white blood cell count because they have an infection or they're on medications that can affect their blood counts, like antibiotics, other antimicrobials, certain seizure medications, cardiovascular medications, and also anti-inflammatory medications, right? And then there's other causes, including malignancies. So for this patient, his workup when I looked at that was essentially negative. His B12 was normal, his folate was normal, his liver studies were normal, no HIV, no hepatitis. He didn't have any recent infections, no changes to his medications, and he was feeling well. So there's another entity called benign neutropenia, right? And it actually kind of follows this pattern, right? You have a healthy patient, no history of infections or hospitalizations, but their neutrophil count is generally below 1.5. It's also most common in patients with ancestry from Africa and the Middle East, where their normal white blood cell count or their normal neutrophil count is actually just a little bit lower, but not clinically significant. And there's actually a test to look for this, and it's called the Duffy antigen. And essentially, when you don't have the Duffy antigen, that's more associated with benign neutropenia. Okay. Really a diagnosis of exclusion, meaning you don't want to miss other things. But when you have no other result and the story makes sense, it's more than likely a benign neutropenia. Okay, so now we'll go on to a little bit of a different case, okay? So another consult for low white blood cells, all right? So this is a 68-year-old woman. She had a history of stage 4 metastatic, meaning spread outside of the original site to multiple different sites. So she had metastasis to her lung from an endometrial cancer. So she was originally diagnosed with that cancer about 5 to 6 years ago after she had presented with a blockage of one of the tubes that connects her kidneys to her bladder. And then she ended up having a hysterectomy and also had to have a procedure for that obstruction. She ended up getting chemotherapy for 5 years ago. And after the chemotherapy, she ended up getting further surgery to deal with the endometrial cancer. She was okay for a few years in remission, but unfortunately developed recurrence of the disease a few years after that, and had a surgical complication as a result of that, where it caused an obstruction in her colon. that required an invasive procedure to treat that. She then was treated with immunotherapy, which people may so immunotherapy is something that stimulates the immune system to try and fight off infection, to try and fight off cancer, and that showed improved cancer burden and disease control after that. So this was about 2 years ago, and then more recently was noted to have developed neutropenia, right? And she was symptomatic from this. She was also developing symptoms in that time period too, fatigue, weight loss, and was having night sweats as well. So this was her initial CBC that I saw. Okay, so not all that different from the prior CBC. Low white blood cell count, low neutrophil count, a little bit more severe this time because it was below 0.5. But one thing I want to point out is that her CBC also showed some other abnormalities too. Her red blood cells or hemoglobin were low, unlike the other patient, and her platelets were low as well, right? And you can see, kind of where in this maturation process, where those cells are involved. We can go to the next. Okay. So as I was saying before, right, it's important the story and the trend over time, right? So here on the right-hand side, I have her CBCs over a few months, as well as a CBC after that initial CBC. And I'm also pointing out some of the important aspects of her story, right? History of metastatic endometrial cancer, treated with chemotherapy, had progression and further immunotherapy after that. And then also had progressive low white blood cells and seemed to be having symptoms that may or may not correlate to that. All right. So you look at her CBC, right? And so the initial one that I have is from the 4th, which I showed you before. But look at her CBC in April. Totally normal, right? White count's normal, hemoglobin's normal, platelets normal. And then something clearly seems to change in the May timeframe, right? And over the course of about a month, white blood cells got lower, red blood cells or hemoglobin dropped and got lower, and the platelets 208 in April now on their way down, right? And then you go down and you look at the differential, which is again the differential is on the bottom. You look at the absolute neutrophil, and that is also decreasing, right? So something is going on here, right? And if you go to the next slide, just one thing I want to point out here, right, is just kind of showing the differences between the first case and the second case. First case, 3 years worth of, yes, low white blood cells, but not having any of the other abnormalities, not having symptoms, not having the same story, whereas the case on the right-hand side is a bit different. So again, looking for different causes, some of the benign causes. But one of the things that I was most concerned about with her, less so about these other more benign causes of neutropenia, was a hematologic malignancy, right? And the most common in this scenario would be something like an acute leukemia or a myelodysplastic syndrome. So what would be the next step? How would I go about trying to sort out whether or not these blood count abnormalities was related to a hematologic malignancy? You can go to the next slide, Sarah. So the next step for me would be going to where all blood is made, right? And that's a bone marrow biopsy, okay? So what I tell patients is that is the factory of all of our blood. That's where all blood is initially made. And a bone marrow biopsy, it's a very common procedure that we do here. It's done in the office, done at the bedside in the hospital. And the best spot to go for a bone marrow sample is actually in the hip bone. Okay. So what I do is I do this under clean conditions, clean the skin around the hip bone. I numb the surface of the skin and the surface of the bone with local anesthetic like lidocaine, and then take a small needle, seen here, go into the bone, get a fluid sample, and then take another small needle, go into the bone and get a bone sample. And then what we're able to do is send that to the pathologist where they can look at the bone marrow under the microscope, and tell us if there's any abnormalities there. And then also send it off for genetic and chromosomal testing to see if there's any genetic or chromosome abnormalities to help guide what the potential diagnosis is and actually help guide treatment for these patients if needed. So we did a bone marrow biopsy on this patient, and what it showed was an entity called myelodysplastic syndrome. Okay, you can go to the next slide. So here I just wanted to kind of describe what myelodysplastic syndrome is. So the way I describe it to patients is that this is basically like a pre-leukemia, right? And there's a wide variety of gradations of that's kind of outside the scope of this talk. But essentially, it's a mixed group of stem cell disorders that characterized by abnormal cells in this whole maturation process, and characterized by genetic abnormalities like I was talking about before. There's different risk profiles with these, and very much based off of the genetic profile, can be based off of the age, can be based off of the amount of immature cells that are there in the bone marrow, and influenced by how it's affecting the blood counts. So how severe the low white blood cells, the neutropenia, are, how severe the red blood cells or the hemoglobin is decreased, and how severe the platelets are decreased. Okay. So like I was saying before, myelodysplastic syndrome, there's multiple different risk profiles. There's lower risk and higher risk. Okay. Lower risk is supportive care, right? Things to bring up red blood cell counts, things to just support the blood counts. Higher risks, almost like a leukemia, needs chemotherapy and a transplant. Okay. And sometimes needs a transplant if you're a candidate for it. So one entity of this, right, is that patients who have been exposed to prior chemotherapy, right? Sometimes this is described as a secondary MDS or MDS that basically derives from blood count abnormalities that have been affected by prior exposure to chemotherapy. Can be a very, very challenging disease to treat because prior exposure to chemotherapy can cause, we try to target the endometrial cancer, right? But there's off-target effects. Off-target effects on, as we know, hair loss, can affect the gastrointestinal tract and can also affect the bone marrow. So when you get exposed to certain chemotherapies, it can affect the bone marrow, right? Which can have long-term risk for developing some of these diseases, right? Which often portends a poorer prognosis, unfortunately, because of the abnormalities that have occurred within the bone marrow. So a lot of these patients ended up needing chemotherapy and and potential transplant. So gonna kind of shift gears a little bit from that case. and refer back to a normal CBC. Okay, so this is the same picture that I showed before, same CBC that I showed before earlier in the presentation. Now, one thing I just want to point out, right, is that, before we were on the left-hand side talking about low neutrophils and low white blood cells, right? But there's the other side too, right? The lymphoid side, okay? And sometimes when you develop hematologic malignancies on that side, or really either side, the overstimulation of those cells and growth of those cancer cells can sometimes influence and impact the normal development of our other normal cells, so normal red blood cells and normal platelets. And I would say that's a general theme in hematologic malignancies. When you have overgrowth of one type of cell, it can have an impact on the normal production of our other cells, right? And we'll talk about a case like that now. So case 3, again, a common consult that I see all the time, abnormal CBC, right? So this man, 65, no medical history, PCP found to have an abnormal CBC. He's on no medication. He's feeling totally fine. But one thing he tells me is that, yeah, the PCP finally said, hey, now's the time to go see a hematologist because these counts have changed so much. And what he told me was that his white blood cells have been increasing, and his lymphocyte, which is a type of white blood cell on the right-hand side, were also increasing. And he's also developed lower red blood cells or hemoglobin and lower platelets over about a year or so. So this was the CBC that they showed me, okay? And what you can see, right, is I've highlighted in red the significant abnormalities here, right? So you can see the white blood cells are high. And when you go down to where it breaks down the different types of white blood cells, look what's really high, the lymphocyte count, okay? Very, very high, okay? But also his hemoglobin is low, right? And his platelets are low, okay? So, just kind of reiterate his story and what's important with the whole picture, right? Which is a theme I want to, a theme in hematologic malignancies. This was routine lab work, meaning he was feeling totally fine. And this is progressively getting, even though I don't have display those, they were progressively getting worse. His white blood cell count was increasing over time. His hemoglobin was decreasing over time, and his platelets were decreasing over time. So what would the next step be, you think, for me? I could tell what you were saying, Sarah, but you were on mute. But yes, it is a bone marrow biopsy. So back to the factory of all blood, and that's what we did for this guy. You can go to the next. And what we found was something called chronic lymphocytic leukemia. Okay, and the bone marrow report showed that he had diffuse involvement of chronic lymphocytic leukemia, and it was 80% of the bone marrow was involved by this process, right? And that kind of makes sense. In the CBC, we saw that his lymphocyte count was very, very high. So I would have expected, something very, very high in the bone marrow. Okay. So what is CLL? So chronic lymphocytic leukemia. So this is a very, very common disease in hematologic malignancies. And what it is it's actually technically a type of lymphoma, even though it's described as leukemia. So it's a proliferation of abnormal lymphocyte clone. So you develop, one of the themes of malignancy is cancer is really one clone, even though that's not 100% correct. It's one clone, one cell that's gone awry. And that's what CLL is. It's one lymphocyte clone that has gone awry. It can present in the bone marrow like it did here, and it's called CLL. But it can also present in lymph nodes, right? Where you have lymph nodes grow very large, and that's not quite a different entity, but sometimes called something different called SLL, which is small lymphocytic lymphoma. Or it can present both ways, right? It doesn't change anything as far as how we manage this or how we treat it. One thing about CLL, right, is that it can be monitored for many years, right? So sometimes people will present not quite like this patient, but will present with, lower white blood cells that aren't affecting their red blood cells, aren't affecting their platelets, and they can be monitored for many, many years. And that's based off of, whether or not they have any symptoms, how their blood counts are going, and what their genetic profile based off of that bone marrow is. When treatment is needed, which was the case for this patient because I was affecting his other blood counts, um, it's not really chemotherapy. It's more targeted therapies and oral medications and immunotherapies that have been really promising in the past, 5 to 10 years. So less focused on chemotherapy, more focused on those types of treatments. So just one thing I want to highlight, which I've been trying to highlight throughout the presentation, is again, this is his CBC, 92 white blood cells, very high. Most of those are lymphocytes. I can see on the bottom part, 85.7%. But with the marrow being 80% involved, it's impacting this overproliferation of lymphocyte is impacting the ability to produce red blood cells and the ability to produce platelets. So that's the reason why his hemoglobin has decreased. It's because these white blood cells are rising and why his platelets are not in the normal range. It's because those cells are pushing out the normal production of the normal processes in the bone marrow. And that's really a recurrent theme in hematologic malignancies, as I said before, that can span across multiple different hematologic malignancies, from myeloma to different lymphomas to leukemias, is that the overproliferation of cells and how they affect the rest of the bone marrow and the rest of blood cell production. You can go to the next slide. So in summary, I just want to point out, the bone marrow is the factory of all blood, as we've talked about multiple times. There's two main cell lines. There's the myeloid side and lymphoid side. We've talked about how myeloid is responsible for certain white blood cells, red blood cells, and platelets, and lymphoid is responsible for lymphocyte production, which has an intricate role in the immune system. Not all abnormal CBCs indicate malignancy, as we saw in the first case. And basic CBC and discussion with patients can really give clues for potential diagnoses, right? So I think that was particularly important for our first two cases, and the third case. And then I also, there's very close interplay between all cell lines, regardless of the myeloid and the lymphoid side, and how that affects bone marrow production and blood production. And again, just want to reiterate, we could spend a long, long time talking about lots of heme malignancies. So this is in no way comprehensive, but just trying to give some insight into, how we look at CBCs and how they can impact, our decision making. So with that, I'll end and happy to answer any questions.
Thank you so much, Dr. McKenna. That was amazing. We haven't done a session like that before, so I know that was it was really informative, and I was taking some notes too. So we can open up the floor for some questions. I will stop sharing my screen.
I don't see anything in the chat.
If anybody wants to unmute or write something in the chat, I know Evelyn and I have a few questions too, so we can ask those too. I had a question about the bone marrow biopsy. Are there any complications or challenges that come with that?
Yeah, so I mean, it's a pretty straightforward procedure. We do it all the time for lots of different heme malignancies. Anytime you do an invasive procedure, there's a small risk for infection, small risk for bleeding. Not, one thing I would say is that the first thing that patients always say is a bone marrow biopsy. Isn't that really painful? And there can be spots within the procedure that are uncomfortable. They're transient, last for seconds. In general, should not be a painful procedure.
Okay. Yeah, because I've also heard that it was painful. So
Yeah.
I
And,
feel
and
like that is the first thing people say.
Oh, it's every single time, it's the not necessarily a barrier, but it's the you spend a lot of time trying to be like, it's it's not as bad as it's thought to be, and I would say by and large that's what people say at the end of the procedure.
Okay, that's good to know. Thank you.
Hi, Sarah. It's Janet. I'm sorry I am in through the iPhone just to listen in to the presentation, but I have a question for Dr. McKenna.
Yeah.
So, and regarding patients with this kind of illness, hematology issues, what is the correlation with patients having leukemia or some kind of lymphoma and heart diseases?
The correlation of leukemia and lymphoma and its correlation to heart disease.
Exactly, with any kind of heart condition.
Yeah, that's that's a good question. I'm not 100% sure what the correlation is. There are certain hematologic malignancies that can sometimes actually like affect the heart. So like systemic amyloidosis is a hematologic malignancy that gets similarly treated to myeloma, and that can certainly have an impact on the heart. Sometimes there can be certain lymphomas, right, when they present in the chest, that can, cause fluid accumulation on the outside of the heart. But actually, I would say, not much of a correlation with hematologic malignancy, that I'm aware of, and heart disease within itself. Um, the one thing I would say that's really important for lots of the treatment that we do is that it is important to know if somebody has heart failure, because some of the chemotherapies that we give for certain leukemias and lymphomas have medications that can actually long-term affect the heart. So something that we think is very, very important to pay attention to, and a lot of times we need to get testing beforehand to make sure that they don't have any heart issues. But direct correlation with certain lymphomas and leukemias and heart disease or heart failure in and of itself, not something that it's I'm aware of.
Thank you for
Oh,
that.
yeah, thank you. Overall, it has been an insightful presentation. Thank you, Dr. McKenna. Thank you.
Thank you.
So we do have a question in the chat. Why are low white blood counts common in certain demographics?
Yeah, that's a good question. I'm not 100% sure. I think it's really just been a kind of when you look at when this entity was first discovered, it was kind of more correlative that maybe the range in which has been picked is not 100% accurate for everybody. I'm not sure there's anything physiologically different about why that is. I think that's just something that's developed over time, and maybe it just necessitates like an alteration as to what true normal versus true abnormal is. And I think that's where the whole clinical context kind of comes into play.
Thank you.
Donna?
Yes. Hi, Dr. McKenna. Great presentation. Thank you so much. I just have a quick question. In the first case you presented, um, I noticed that you did not do a bone marrow biopsy, if I have it right, in this
Yes, that's
presentation.
that's 100% true.
And yeah, I know you went over the CBC in great detail and the diff, but I was just wondering if in that case you would see that patient having a predisposition for myelodysplastic syndrome?
I'm sorry, say that again?
Would that patient have a predisposition for myelodysplastic syndrome?
So that's a very good question, right? So yes, I did not do a bone marrow biopsy, and patients that have benign neutropenia do not require a bone marrow biopsy. If I had done one, it would have been normal. So you would have seen what I call is normal trilineage hematopoiesis. Basically, that's a fancy way of saying the bone marrow is developing normally, all the red blood cells are developing normally, all the neutrophils are developing normally, all the platelets are developing normally, all the lymphocytes are developing normally. Um, and there is not a predisposition to MDS. This is a pure benign process. Now, it's always in the back of my mind with patients like this, being like, benign neutropenia is a diagnosis of exclusion, right? Meaning, you wouldn't want to miss an MDS. So I do continue to watch these patients and ask that, when I first meet them over time to kind of get an idea as to what's going on with their counts and if they do develop any new symptoms. And, if anything changes with that, then I would go to a bone marrow biopsy, just to make sure. But in general, when you see these patients, it's not necessary to do that right in the beginning. I would say over time, it's something that I think about until I, know somebody for, a few years before I say, hey, I think we're okay. You can go back to your PCP.
Thank you. And then I have another question along the same lines of myelodysplastic syndrome. I saw that one of the risk factors was aging.
Yes.
And our population is aging. So is there a greater number of cases you're finding of myelodysplastic syndrome because of our aging population? And then the next question to follow up on that is, when diagnosed at the more less acute phase, what is the life expectancy, or what is the expectancy before conversion to leukemia when diagnosed with MDS?
Yeah, so those are great questions. So I would say this is pretty much across the board, right? That as we age, we're just at increased risk for not being able to handle the mistakes that are made in cell replication, right? So that's a general theme in all of oncology, whether it's lung cancer or MDS or leukemia or skin cancer, right?
Mm-hmm.
We're going through billions, trillions of cell divisions constantly, and as we age, we're less good at correcting mistakes that occur during that process. And that's essentially broad strokes what leads to these entities. So that's across the board, I would say. Aging population, just an increased risk for basically all heme malignancies, all malignancies, all pre-malignancies.
Mm-hmm.
Regarding the risk profile, right? So one of the most major components of MDS that's very important is the genetic profile, right? So I would say, by and large, in almost all heme malignancies, it is very, very important to know what the genetic profile is of that abnormal entity. So when you see somebody who has, very high risk mutations, a very abnormal chromosome, as my patient did, that's a much higher risk MDS. When you look at somebody who comes to me that has not just, but has an abnormal red blood cell count, right? A lot of times you won't see any of the immature cells that can be associated with higher risk. You won't see those genetic abnormalities, right? I will say those can progress to a higher risk MDS over time, but it can take a lot more time than kind of this presentation, which is almost akin to a leukemia. And actually, some people will actually say this is a true leukemia as to how she presented to me.
Okay. Thank you so much.
Does anyone else have any questions? I actually have a question. For your third case study,
Yeah.
how was the gentleman feeling? I'm just curious if all of this was only caught because he had been getting his blood work done.
Yeah, that it definitely I think that's what he really had no symptoms. And even though he's on treatment, still has no symptoms, right?
Wow.
The problem is that over time, I would have expected he would have developed symptoms, right? So and probably the way in which his symptoms would have developed would have been due to the anemia, right? He would have been more tired, right? Um, that probably would have been the way his symptoms would have developed, and that's probably when he would have eventually gotten lab work and then come to me. But the question about whether or not it was important for him to like catch it earlier, that's I would say with probably not with this specific case, probably not as important because a lot of CLLs you need to watch over time. You can watch over time. It's really when you start see, and even the white blood cell count, far less important in this disease entity than certain other ones. Like if this was a case of AML, very, very different. That would have been emergent treatment. CLL is a little bit different. It's more based off of symptoms, his trend over time, how quickly these white blood cells are dividing, and how it's affecting his other counts. And that's really where the decision, after a few visits with him, came to start treatment.
Thank you. Does anyone else have any? We have time for maybe one more question. Okay, then I'm going to jump in. Hold on. So what percentage of chemo patients do you think get secondary blood cancers? Or if you don't want to answer that one, I have also, can diet affect white blood cell count? Whichever one
So,
is easier for you or
so diet, I would say diet can, well, one of the things I always ask people is, are you a vegan, right? Vegans don't sometimes there can be B12 or folate
Mhm.
deficiencies
Yeah.
with vegans, right? So that's an important question, and that can affect your nutrients and the impact on your white blood cells. I would say chemotherapy is a broad category. There's certain chemos that are more associated with secondary malignancies, secondary MDSs, and secondary leukemias. And when I say secondary, it means somebody who's been exposed to one of the definitions is someone who's been exposed to chemotherapy before and then develops a hematologic malignancy. Um, I would say, single digit percent, like low single digit percentages, but there's very specific chemos that are associated with it. It's not all chemotherapies. So, just something that to keep in mind.
This was fantastic. Thank you.
Yes,
And
thank
as
you
a vegan,
for.
I can attest to always having it on the lower side. I don't know if anybody else was looking at their CBC panels while Dr. McKenna was presenting.
Yeah, and one of the things that it's there's red numbers all over the place. Every CBC that you get, and it's all the clinical context, it's all the story, it's all that's really really important with the whole thing.
Thank you, everyone, for asking questions, and thank you, Dr. McKenna, for answering.
Sure. No.
I have a few wrap-up slides, and we have the post-test, so we'll do that now too, actually. Um, current slide. Okay. All right. So if everybody wants to do the post-test real quickly, and then Dr. McKenna can go over the answers in the next slide.
Let's just give it a second because I don't have, is everybody, okay, there we go. I wasn't sure if it actually launched. Let's give it maybe like 30 seconds just to get a quorum. I like to get at least 75% participation. Right now we're at 20%. So if you are able to do the poll, please do it. in the essence of time, I'm going to go ahead and end it. Oh, I know people are still doing it. I'm sorry. And then here are the results.
I'm gonna go to the next slide. Okay.
Yeah, so all blood made in the bone marrow. So that's where we have our stem cells and then the two lines, and then everything gets produced from there. Low white blood cells don't always indicate malignancy. There's lots of different causes for low white blood cells, but something to keep in mind, that can be a presentation for malignancy. And then if you have an abnormal CBC but no symptoms at all, does that rule out malignancy? Well, no, because in the last case, it was an incidental finding of an abnormal CBC. Patient was feeling fine, still feeling fine, and ended up having an indolent type of lymphoma called CLL.
All right. Thank you so much, Dr. McKenna. Thank you, everybody, for attending. So just some last minute slides. We have NJ Seed in New Jersey. They offer free cancer screenings, breast, cervical, colorectal, and prostate. And the phone number and the link will be in the chat. Thank you so much for attending today's session. Please let us know how we did. We really do look through these evaluations, so thank you. That'll also be in the chat, and I can go back to that after. So join our Mighty Networks community. This will all be posted to Mighty Networks, and Dr. McKenna also has access to our Mighty Networks. So if you have any questions, feel free to ask it over there, and I can let him know. And the recording, the PDFs of the slides will be there as well as any other material you want to share, Dr. McKenna. We can put it on there. And then join us next month on May 13th for a session on oral cancer screenings. And yeah, thank you so much for attending today's session. Um, I'll go back to the evaluation slide in a second. Thank you so much, Dr. McKenna. We really appreciate you being here.
Thank you, everybody.